We have private security, which was provided by the executive to the hospital. We also have, we are putting also in place CCTV camera to make sure that we monitor patients and others coming into the hospital. So thank you very much.
Auditor, your comments on the response by the executive?
Yeah, Chair, I think I'll be guided by you because the issue that we have, they have put the measures, the policy in the process. But the issue of money lost has not been accounted for. But maybe you can give your own view. But for us, is maybe we review when it comes for 24-25.
Okay, let me open it to members. Your questions, comments. Senator Mbugu.
Thank you, Chair. Maybe the management should tell us how far you've gone in developing a waiver policy, because you just don't have. There are those people who will never pay, and maybe they are not in charge, but there needs to be a policy on the way to do it.
Yeah, Chair, we have a waiver policy covered as part of our FIF Act, and there's a waiver committee. So now there's a process to waive. And as the CEO of the hospital here said, this was rampant before we secured the hospital with a security wall. It had a porous wire mesh wall. Now it's got a perimeter wall, and the gates you can only access through gate passes because they're manned by private security, and we even pay some KPRs and people like that to back them up. It shouldn't be an issue that arises. And as I said, because of the mindset of free budgeting, I think I'll be more worried if they stayed away and died than if they came and they, quotes unquote, absconded. Because I said it's not possible that they just abscond. Probably it's the nurses who were there that were releasing them because they were doing them a favor and calling it an abscondment. So, because I know our culture. Having said that, to try and reduce that, we will actually provide share premium for those that cannot afford. Yeah, thank you.
Any other issue, members? Senator Abbas.
Thank you, Chair. I think my question is, Ghana, that besides the people disappearing the money, and as rightly said, of course, anything can happen, the kind of people we have. What I've seen is that the share money actually is being released, is being given at source. It goes to health centers, the laboratories and lab floors and all these places. Is there any system that you can be able to track this fund? Because I am being told the money is being used at source at times. So I don't know how you'll be able to control the use of funds and how you'll be able to track. Is there any kind of auditing systems? Is there any kind of tracking system that can be able to know whatever I was saying have collected is genuine amount that is collected? Is there any, any such a system, anything that is used to be able to track the funds? Because as it is, the funds will be used at source. You expect a lot of leverage. So I don't know whether you have to, council have any kind of systems on tracking funds.
Yeah, Senator, your concerns are genuine. I think FIF has solved one problem and created another. The problem that it has solved is that it has caused enthusiasm at the facility level, because now they know when they treat patients and they make claims, there's some money that will come to them which money will be available for improvement of that facility. On the other hand, it has caused a mindset of absolute autonomy. So much so that the hospital superintendents that are managing some of these facilities think it's their money, frankly. So what we've tried to do, and for the major hospitals, the ones that, the sub-county hospitals, for instance, is to require a team at the center that consists of health and finance to approve their plans. So if they come and say, these are the things we want to spend on, we tell them, no, this thing can't cost this much. We look at both the quantum and we also look at the prioritization. And there is a point that I have kept drumming, that we would want to see a wing in a facility that has been constructed out of FIF money. Because the bulk of the hospital expenditure is still supported by the equitable share budget, and putting in more than 3.7 billion shillings into the healthcare system every year. I am hoping over time some of the things that I'm paying out of the executive will be taken care of by the FIF, and that money will be available to do other things, to do town planning, to do agriculture, to add to water, and, because under SHA the hospital should be able to pay for itself. We might also need to relook at the FIF Act to have that money coming to the center first and then releasing it on an AIE basis under some sort of approval, so that, because there's actually a fight always between the managers of the health facilities and the people at the center. The health facility will tell you, but this is our money. But I haven't seen them construct their own hospitals. So it's a challenge, and it's a challenge across all the 47 counties. We came with a good idea, but now it might also cause some fraud in the SHA. Because when people realize that money is staying with you, then claiming money to get more might in itself be, an end game, as opposed to treating people. And this is why you've had CS Duale always complaining about people claiming inpatient beds. You find a hospital claiming 60 inpatients in a night, but they only have 20 beds. We are not immune to these things also in the public facilities. So we just have to rethink how to run SHA, because SHA is a very good idea, but knowing the mindset of our people, and the whole issue of corruption being pervasive, it pervades everywhere. You don't rule out that even our own facilities will try and stretch their revenue generation by being fraudulent. And those are things we have to deal with. So we might want to have a conversation between Senate and the Council as to what can be improved from a control perspective in this FIF.
Governor, I think you spread drugs to these various institutions, hospitals, in the various parts of the county. And then those drugs come directly from KEMSA or you purchase. So what is the role of the recipients, like the health centers, the dispensaries? In some dispensaries, they don't pay money. But of course, level 3s and 4s. How will they account? The drugs you're giving them, you bought it from KEMSA, from the facility fund of the county. So how will they pay back that money to, so they can be able to get their drugs? Is there any system that you can be able to have so these guys can be able to purchase drugs from a central store? So they pay for the drugs that they are, because the money is going to them. And I think the money cannot only be used for only facility improvements. They must be able also to be sourcing their own drugs, because that knows that the money is there.
Yeah, Senator, that's another issue that we're grappling with. So far, I know there are counties that have linked the facility directly to KEMSA so that they're able to pay for their own drugs. In our case, we buy the drugs in bulk from KEMSA. Our first point of call is KEMSA. KEMSA gives us what they have. Then they generate what is called an unsupply list for us for the things they don't have. Then we have framework contractors that supply us with those others. And then we deliver the vendor. In the case of KEMSA, which is the bulk vendor, does a last mile delivery. It doesn't come through the center. It goes directly to the facility. Thus far, we have not required the facilities to pay for the commodities. We have been paying ourselves. But as we register more people, because our registration level is also among the lowest in the country, I think by the periphery standards, we're not badly off, but we're still hovering around 25%. So my aim is to take that to about 50-60%. And this is why I'm willing to pay for those that can pay. Once we're able to do that, then these facilities will generate a lot more money, and then we can think of a mechanism to charge them for the drugs. We can either have a billing system at our product management level, where the chief pharmacist then is able to bill to the individual facilities, or we link the individual facilities directly to KEMSA. These things are all at the formative stages. It's an improvement. Frankly, it's a massive improvement. So I get agitated when I see people saying, SHA is useless, it's a scam, because I know what's happening on the ground. But yes, there are gaps. We just need to continue improving. But the first gap is to get as many people to register as possible. And I would have appreciated, even if CDF, for instance, can chip in to register some of the indigents in their constituencies. For now, we're paying for the drugs, but eventually, we have to have them paying. These systems, because the thinking is very simple. How is a private hospital that is even paying rent able to meet its own expenditure and still make money? Because people know when they go to a private hospital, they pay. So if we can get everyone on SHA, and we get our money from SHA, because we're not paying rent at the dispensary, that money should be able to cater for a lot of things. And it should free up money to do other devolved functions. I yield back to you, Chair.
Very well. Any other issue, honorable members?
Chair, we said that we should have left by 11 o'clock, so, we agreed to come to this meeting, and, as we have other engagements and some flights to take.
So I think this one I direct the auditor, is you monitor to ensure that the county has set up appropriate security measures to prevent abscondment and also general security for the hospital. And we will review that in the next audit meeting on the hospital. So, honorable members, let's proceed to the issue of deficiencies in the implementation of universal health coverage. And this also touches on issues of staff. So, honorable members, as you make your comment, also note that there was a query on lack of an approved staff establishment. So we can discuss those issues as we look at this one. Auditor, you can make the query, please.
Thank you, Chair. Deficiency in implementation of universal health coverage, UHC. Review of hospital records and interviews conducted on the verification of services offered, equipment used, and medical specialists in the hospital at the time of audit revealed that the hospital did not meet the requirements of the Kenya Quality Model for health policy guidelines due to staff deficits as announced below. So we have a table which shows the required number, the level of standard of staff, the number in existence, and the variances. We also have, in addition, they also lack the necessary equipment and machines outlined in the health policy guidelines below. Again, we have the standard required, the actual, and the variance. So, in summary, the deficiency contravene the first schedule of the Health Act 2017 and imply that accessing highest attainable standards of health, which include the rights to health care services, including reproductive health care, as quoted by Article 43, subsection 1 of the Constitution of 2020, may not have been achieved. Further, this contravened the Kenya Quality Model for Health Policy Guidelines and hindered the resolution of the government program on universal health coverage. Thank you, Chair.
Okay, members, I think you need to understand the tables, the two tables for our discussion. So, Governor, you can give your response.
Mr. Chairman, the hospital has some health cadres that do not meet the threshold required for level 4, while other cadres surpass the threshold. One of the major constraints is budget to cover the expenses, as the county is currently above 35% threshold for personal emoluments as per the requirement of the Fiscal Responsibility Principle according to the PFM 2012. Mr. Chairman, the executive is progressively ensuring that the right staffing levels are achieved to provide quality healthcare services. Further, the County Public Service Board recruited 212 healthcare workers for various cadres to address the gap. Of the 212, the below staff were posted to the WAJIR County Referral Hospital. And you can see listed there nurses, 30 radiologists, radiographers 6, medical officers 5, clinical officers general 3, clinical officer anesthesia 2, pharmacological technologists 3, laboratory technologists 1, dental technologists 1, health records and information officers 5. Further, upon the completion of the new ultramodern accident and emergency wing that's currently under construction, the hospital bed capacity will increase by a further 102 beds. This will include 50 bed capacity wards, 4 private rooms, 11 bed HDU and 12 ICU beds, 12 accident and emergency ward beds, 5 beds pre-operative room, and 8 beds post-operative rooms. This will translate to a total bed capacity of 222, surpassing the requirement for a level 4, which is 150. Mr. Chair, if you look at the first table, it's only in 2 places that we are short of the requirement. That is in anesthesiologists, and that's a mouthful, and radiologists. Now, we had sent some of our doctors for training to train as anesthesiologists. One of them has already returned. So in place of 0, we now have 1. We have the clinical anesthetists. Those are the ones that have been working. But now we have 1 consultant anesthesiologist. For radiology, because we didn't have that many in college, I have allowed them to recruit. I've told them to advertise and recruit. We actually need a lot more radiologists now because of these NESP equipments that have already started being delivered. So we are in the process of recruiting radiologists through the board, and also anesthesiologists. 1 has already arrived and we'll get another one. But notwithstanding that we are having a challenge with the ratios, payroll ratios, to fully operationalize the new wing, we will have to recruit another, give or take, 150 people, nurses, and all the works, especially ICU nurses, HDU nurses. So we'll take a little bit of beating for the ratios, but the ratios should also improve, because the ratio is wage bill as a percentage of revenue. With this new NESP equipment, with this what we're trying to do for the indigents by paying premiums for them, what we will be getting from SHA should be able to boost our revenues to make the percentage look a bit better. Having said that, Chair, I want to assure you, if we need someone for healthcare, percentage or no percentage, I will recruit. Thank you.
Okay. Auditor, your comments on the response?
Thank you, Chair. I'm not blowing the whistle of the governor, but looking at the percentage, I think he has tried, especially in terms of medical officers, where he has a positive ratio. When you look at even at the renal units, which is very critical, he has surpassed the standard. So from his response, I think, Chair, I'm satisfied. But there's room for improvement. Thank you, Chair.
Indeed, members, if you look at the governor's response, the table on the governor's response, you compare it with the table, the first table in the query, then you can see there is some improvement. Because, for example, on the medical officers, there was, it's actually an excess considered to the standard of 6. They are supposed to have 16, they have 22. But they have also gone ahead and recruited 5 more. So compare the two tables, then you see there is an improvement. But on the issue of table 2 of the query, there is the issue of the number of beds, which is still short by 30, and also the number of ICU beds, which there is a deficiency. To be done. And then also, Governor, you tell us about the nest. The nest that is COG, you have agreed. The nest which is the mess. I don't know whether the nest is also a mess. You can tell us. So let's combine the queries and then the governor will respond. Senator Kisang and then Senator Mbogwa.
Chair, mine is, we said we combined this particular query with the staff establishment. So we wanted to find out also from the governor if the hospital already has an approved staff establishment or they're still in the process of having one, so that, we match the two queries together and basically clear.
Chair, it looks like when this ultramodern accident and emergency wing is complete, there will be some positive changes. Maybe the governor can tell us when it is going to be completed and how far it is at the moment.
Thank you, Chair. Establishment, because this facility is now moving from a level 4 to a level 5. We've actually been given the certification already. And as I said, it is contingent to fully operationalizing the new wing. We are, through the board of the hospital, looking at the new required establishment. The board is chaired by consultant gastroenterologist. It has very serious people in there, and they're doing a very good job. We are hoping the construction of the facility is complete, and we're equipping it piece by piece. By end of October, that facility should be fully operational. Then the question of ICU beds and HDU beds will not be there, because you can see it has 12 ICU beds against a requirement of 6 actually, and 12 ICU beds. So we work to ensure that it's up and running by end of October. Where it's too critical, such as even the dialysis machines, we even went ahead and bought our own, even as we waited for the NESP. We bought 6, and we're getting a further 6 from the NESP, so we'll have 12. So, Chair, I want to assure you that these ratios will be surpassed in the next few months when that other facility is up and running. On the issue of NESP, Chair, and I'm supportive of the NESP program as a council chair. And reason being, the amounts that we need to use to buy equipment are not amounts that we can absorb within our budget. And if you look, for instance, under NESP now, if you look at it now, I have new, what are they called? The full hemogram machines, the ones that we took to the sub-county hospital, the blood machines. And biochemistry machines in places that, didn't have those, very peripheral places. We've already gotten the CT scan. We're getting MRI units and stuff. So these are things that will cost billions of shillings. And given especially for counties that don't generate a lot of their own on-sales revenue, we want to leverage on the bulk purchase. And this is also fee for service. The vendor who is on a PPP arrangement will be getting their money from SHA. But what, as chair of council, I have done, because I don't want this to be called a mess or a criminal enterprise after I've left the scene. It can have personal reputational risk issues on me as a person. And we have carried the governors along. We have used expertise in the council to ensure that whatever arrangements are arrangements that the council has ensured are above board. And whenever there is an amendment to either the funds flow or anything, then we go back to a full council meeting and give every governor an opportunity to have their say, and we only move forward on a consensual basis. The difference between this MES and NESP is that under MES, there was a bit of caution. Here, there's no caution. In fact, 2 counties are yet to sign up. They have said, we're not signing up. And we're telling them, if you find it useful, sign. There are others that have signed up, but have not made full requests. There are others like me that have signed up and have made full requests. Because for me, from where I sit, more than anything else, having the machine delivered and working for my people is more important. So I wouldn't think it will be called a criminal enterprise like MES. I want to assure you that if I feel there's something that's not been done for the right reasons, in the right way, I'll be the first one to shout. But so far, so good, Chair. Thank you.
Sorry for taking you to the issue of NES because it's not part of the query. But you are now wearing 2 hats. You are the chair of COG and the governor of WAJIR. But so we just need to know. The complaints we have received are that yes, NES provides the equipment you want. They are able to service the equipment, but then maybe you can tell us about the revenue sharing, because there has been complaint that the revenue sharing model is not favorable to counties. Maybe they take more than they should take. You can comment on that.
Chair, on the revenue sharing, again, this was negotiated through an elaborate process. As a council, we gave our, proxy negotiation rights to the Secretariat staff of the Council of Governors. We even brought in a few experts from a few of the counties. It's on the certain critical machines that probably the counties are feeling more is going to the vendor. But when you look at the vendor's argument also is those are machines that are very, very expensive. And if the traffic, the volume of transactions in terms of number of services offered is not sufficient, then the vendors themselves may actually make losses on some of the machines. So it's not a standard percentage, and I don't remember all the percentages of it, but it's different percentage for different machines. But overall, for a full council meeting to have accepted, the governors must have processed and said, then it's fair. The challenge is now coming from our own staff, because our staff are used to the old mess arrangement where machines were delivered and we were charging for those machines and taking all the money ourselves as counties. So compared to that, then they'll see and their revenue has reduced. But actually what they don't realize is their revenue had actually reduced at the sharing level because there was an inbuilt conditional grant to every county that was being deducted at source. And the legality of deducting an conditional grant at source itself was one of the reasons why MES was deemed an illegality. So the pushback is more from the staff, but the governors have in principle accepted that it's okay to have those percentages. And it's for the more expensive machines. You know, if you're going to give me an MRI, and I don't have one now, and I can't get it from my budget, and after you give me, you're not asking me to pay for it through my equitable share, and you're still leaving me with a little bit of money to help with the staff costs and everything, and they're the ones who are doing maintenance, because the biggest cost in these machines is maintenance and consumables. Consumables and maintenance are the biggest cost. The contractual uptime is 95%. So at least at 95% of the time, the machine should be up and running. I think it's a good, it's a good scheme, Chair. Knowing also, sometimes as counties, we struggle with repairs and maintenance. Whether it's in terms of staff capacity or in terms of the mindset of Malia Uma, so if you can have someone take the responsibility for the uptime, I would rather have the dialysis machine working at all costs, because this is about somebody's life and death. I thank you, Chair.
Senator Abbas.
I am not sure, but I think on the side of health, the government is trying its best, and especially on the stuff of the HR. So actually, there are many doctors who improved. Yeah. And we're waiting the new building, level 5 to open. It's a very complex. So that part, I commend the good work of the governor. So I have not to say about that.
Yeah, actually, the governor, if you complete the complex and equip it by October, as you say, then I think the auditor agrees that the query would be resolved completely in terms of aligning to the standard that Ministry of Health has set. So, honorable members, I think that brings us to the end as per our plan that we only deal with queries which were not addressed by the county. Now I request that if you have any closing remarks, you can make. If you don't, then the governor will make a closing remark. Senator Mbogo.
Chair, I think it is important we appreciate the governor because he's an accountant. And from the previous reports we've been engaging, there were very many issues of errors, inaccuracies, and late submission of documents. At least that one was good for you. And you are proving to be a real accountant. The other issue I want to bring to your attention is that this morning, 40 facilities have been suspended from SHA. And it's good to note, I've seen the list, only 2 are from WAJIR County and very many from your neighbor Bandera, so you are doing well.
Chair, maybe we can visit the county after October, maybe so that we can visit the hospital. I wanted just to find out from the governor, how far is the industrial park? Because it was it was something very nice and it was helping your people. I don't know what's the actual status now.
Industrial park is not part of our meeting today. But he will respond in his final comments. Senator Abbas, your final comments.
Thank you, Chair. Thank you. It has been a very good day. I want to tell the governor to continue with the good work. And one thing is actually, I want the semi-autonomous institutions like municipality, WAJIR, ESCO, and even the hostel, the fire hostel, should be able to have any kind of an autonomy now to work on their own, so they can deliver properly. Because with the kind of management they're doing, micromanagement, they will have their own facilities, they have their own staff, everything. I think even the workload on their side will be reduced, and they can take accountability on everything that they do.
Governor, your final comments.
Thank you, Chair. Just to respond to a few of the issues that Senators made in their closing remarks. With respect to the closure of the 2 facilities, Chair, as I've said, the biggest threat to SHA is fraud. And if there is fraud, whether in the public sector hospitals or the private sector hospitals, we must be very firm. We must deal with it. So if one of my hospitals is closed because of fraud, I'll deal with it. Chair, just to put into perspective, immediately after SHA, I think the number of private hospital facilities within the 4-mile radius of WAJIR town has more than tripled. Every other building says we're taking SHA. We're taking SHA. So everybody is trying to cash in. But this is an insurance scheme. Insurance works on the basis of pooling risks. Insurance will only work if not everyone who is insured claims. So we have to protect SHA from fraud for the sake of the ordinary Kenyan. I will do my best to ensure that the main facility is open by 30th of October. Chair, one of the success stories that I give about devolution is how the hospital system has moved in WAJIR County. We had 1 doctor in 2013. Today, we have 75 doctors in our payroll. We had no consultants, now we have consultants. You can see we have 22 medical officers in that one hospital only. So this could not have happened without devolution. So with all the challenges of devolution, with everything that's said about it, those are some of the gains. I take the comment about autonomy of these facilities very positively. It's a process, it's not an event. We will work towards ensuring full autonomy for all of them. And I would be very happy the day it's not me, but the hospital manager sitting here with his board to answer queries. WAJIR CEO with his board to answer queries. And I would also want the Senate to move that way. That yes, we call the governor for the overall county accountability, but to enhance individual accountability, I think the CEOs of some of these facilities and institutions should be the ones. It's part of also capacity building, so that, because when there's a problem in KNH, I think it's KNH CEO that's called, probably also in addition to the minister. But Senator Abbas, I take that very positively, and we have made progress. We have a working board for the hospital. We have a working board of professionals for the WAJIR. We have a working board for the hospital, for the municipality. On the CAIP, the County Aggregation Industrial Park, we were slowed down because the national government's share of resources delayed. The contractor moved very fast, and then at some point stopped because we were unable to pay him, and we had exhausted, because this was a co-investment. It was a co-pay. Matching grant was to come from Ministry of Trade. They have now released some money, and the contractor is back on site. I am hoping that ours will be one of those that within the term of this government would have fully been completed, operationalized, and working. In terms of percentage completion, it's one of those that is slightly ahead of the others. Chair, I want to thank the committee. I want to thank you. I want to thank the technical staff and the partners for a very cordial and professional session of audit review. The Senate has reminded me that I'm an accountant. I usually tell my people reputational risk is more on me when things don't work. So I'm usually a bit brutal with my team. And that's why you're seeing, in spite of the past mess, at least out of the 5 reports discussed here, 3 had a clean opinion, and the others didn't show any loss of money. It was more policy and process improvements. And I am of the view that an audit will always have recommendations. It will always throw out something. There is no perfect world, but we'll do our best to ensure that there's no money lost on my watch. There is no issues of non-remittance of pension or statutory reductions, and that there is value for money in the things that we do. And we will always take criticism positively. I end it there, and I thank you, Chair.
Thank you very much, Governor. First of all, I want to thank you for accepting our invitation to appear before us. I know the responsibility you have as the COG Chair, and I also thank that members, you are able to create time on a Friday. Ordinarily, we don't meet on Friday, but because this meeting was supposed to have held yesterday, the governor was attending a COG session in State House, so we agreed to push this to today. So, honorable members, thank you for that perseverance. I want to also thank the county, because there has been some improvement since we started engaging as a committee. You remember on the matter of water, we had a lot of problems in the audit report, but there appears to be an improvement. And now we are seeing improvement even in hospital and the other entities. I think that's the way to go, and that tells us the important role that oversight plays in ensuring accountability and things moving in the right direction. This is the role we want to play as senators, not because we want to antagonize ourselves with governors, but because we just want to ensure that people get value for the money. And we can see the progress that is being made in the area of health. I'm actually impressed by that, but we look forward to visiting WAJIR ourselves, maybe in the month of November. Clerk, you can organize that so that we see the new facility that will be ready by October. Otherwise, we will always want to engage in a very constructive manner. We know that some of these entities have semi-autonomous status, but governors, at the end of the day, Article 179 puts the executive authority in your office. So that's why senators would always want to hear from you. But I want to recommend that maybe next time you come with the relevant board chairs, for example, the board chair of the municipality, so that he can respond to the specific issues senators are raising on matter of municipality, and also the board chair for the hospital to respond to the specifics issues that members are raising. Otherwise, thank you very much. And honorable members, we want to wish the governor and the team safe travel to WAJIR. And you know we're having devolution conference starting on Monday, so we will not have any meeting. The next meeting will be on Monday, 18th August, 10 a.m. So we adjourn until then, honorable members. Thank you.